Hello everyone. Welcome back to the series of lectures in medicine. Today we'll be starting off with hepatology. So the first topic that we have to learn under hepatology will be your approach to liver function tests and hyperbilirubinemia. So let us begin. Before we understand the approach to liver function tests, let us understand the basic architecture of the liver. Right? So the liver basically can be divided into multiple hexagonal lobules. So the liver can be basically divided into multiple hexagonal lobules. So each of these lobules is what we call as the basic structural and functional unit. Right? So if you just enlarge each of these lobules, each lobule is hexagonal in shape. So if you just enlarge and have a look at it, let us look at it in a cross-sectional pattern, right? So the liver, when you understand the blood supply of the liver, the major blood supply is basically by the portal vein, right? And the portal vein drains into the liver along with the hepatic artery. Then you have the hepatic vein which comes out and drains out of the liver, which is your hepatic vein. So if you take a cross section with the hepatic vein in the center around it, so hepatic vein in the center and surrounding this is your portal tracts at 6 locations which basically form the hexagonal lobule, right? So if you look here, this central vein is your hepatic vein. The central vein basically feeds into your hepatic vein. So each of these lobules is hexagonal in shape. So because it's hexagonal in shape, it is surrounded by hepatocytes and portal tracts in your 6 corners. So the hepatic vein is here and in your 6 corners you have your portal tract, right? So what is this portal tract? So portal tract basically comprises of portal vein with the bile duct and a branch of hepatic artery, right? So this portion. So portal vein, bile duct and hepatic artery come together here and similarly in your 6 corners. Okay. So you have branches of the portal vein along with the bile duct and hepatic artery which form your portal tract, and you have the hepatocytes which basically are arranged in this pattern, and this goes and drains through what? Drains through channels which are called as the sinusoids into the central vein which drains into the hepatic vein. So the basic principle here is, if you enlarge it here further, here we have the portal tract. So what is the portal tract comprising of? It comprises of the portal vein, the hepatic artery and the bile ductule. And all of these drain through channels and they connect the central vein. Okay. So if you see here, the hepatic artery and the portal vein join together, and what do you find inside this? You basically find RBCs and they move through a channel. This channel is what we call as the sinusoids. This is what we call as the sinusoids. Okay, this is what we call as the sinusoids. These sinusoids are then surrounded by your hepatocytes. This is surrounded by your hepatocytes. So the space which is basically present between the hepatocytes and the sinusoidal membrane is what we call as the space of Dicey. Is what we call as the space of Dicey. And can you find some purple colored cells here, right? The purple colored cells are what we call as the cells of Ito. The cells of Ito. So what is the function of these cells of Itos? These are the ones which basically produce transforming growth factor beta. They produce transforming growth factor beta. So whenever there is cirrhosis of the liver, cirrhosis basically means that there is fibrosis of liver and there is destruction of the liver architecture. So it is these cells of Ito or the stellate cells, they are also called as the stellate cells, which get activated and they secrete transforming growth factor beta, which is basically responsible for the fibrosis. Apart from that, within the sinusoids, we also have few macrophages. Okay. So this is the basic structure of your sinusoid. So you have the channels which are created from the portal vein and the hepatic artery. forms a channel which connects to the central vein. Okay, this is surrounded by your hepatocytes which are arranged in this pattern. The space between the endothelial membrane, the sinusoidal membrane and the hepatocytes is your space of Deci. Within that you have the stellate cells which basically form the chief cells behind the pathophysiology of cirrhosis. What about the bile duct? The bile duct then forms a separate duct. It goes, the bile ductule, it is not a duct. The bile ductule forms a separate ductule which goes and drains into the bile duct and it carries the bile. Okay. So this is about your basic architecture of the liver, right? So the liver basically can be divided into functional units which are called as your hexagonal shaped lobules. Each liver lobule comprises of a central vein in the center which drains into the hepatic vein, surrounded by 6 corners which each of it is a portal tract. The portal tract comprises of the portal vein, a branch of the hepatic artery as well as the bile ductule. So the portal vein and hepatic artery form channels which carry the blood to the central vein, and this is what we call as the sinusoids. Then the space which is present between the sinusoid and the hepatocytes is your space of Deci, and this has certain cells which are the cells of Ito or the stellate cells which are responsible for the fibrosis in your cirrhosis. Okay, and then the bile ductules drains into the bile duct. So this is the basic architecture of the liver that we should understand. Now let us move forward. Let us understand this concept of bilirubin metabolism and transport. Let us understand bilirubin metabolism and transport. So we know that bilirubin is basically produced by the breakdown of heme. Heme is obtained from the RBC. So when the RBCs break down, the byproduct is your bilirubin. So how is this formed? Heme is converted into biliverdin by heme oxygenase, and biliverdin is converted into bilirubin by biliverdin reductase. Okay, so heme is converted into biliverdin, which is converted into bilirubin. Now, this bilirubin that is produced from the heme is your unconjugated bilirubin. This is your unconjugated bilirubin. Okay, and this undergoes a conjugation process in the liver. The bilirubin becomes conjugated within the liver. It is then excreted in the bile. So this is the transport that we are going to understand in detail. So this bilirubin which is the unconjugated bilirubin UCB, it combines with albumin. It is transported with the help of albumin. So we are basically looking at the sinusoid. So we know that we are basically looking at the sinusoid, right? So we know that bilirubin is produced from heme. So within the sinusoid itself, the unconjugated bilirubin combines with albumin and then it gets transported to the hepatocytes. So from the sinusoids, it goes to the space of Deci and it goes to the hepatocytes. So once it enters the space of Deci, this albumin is removed and the unconjugated bilirubin is transported through 2 very important transporters. The 2 very important transporters are your OATP and the bilirubin transporter. So can you see here that it goes like this? It goes through into the hepatocytes via this OATP and bilirubin transporter. Okay. So once the unconjugated bilirubin enters into the hepatocyte, it has to undergo conjugation. Conjugation with what? It gets conjugated with your GST, which is your glutathione. Right. So the unconjugated bilirubin combines with glutathione and it forms conjugated bilirubin. So this conjugated bilirubin is formed by, so this conjugation process is brought about by the help of an enzyme, which is this enzyme, which is your bilirubin uridine glucuronil transferase, which is your uridine glucuronil transferase, which is your UGT1A1, which helps in the conjugation of bilirubin. Right? So how does this conjugation happen? With the help of this enzyme, this bilirubin is converted into bilirubin monoglucuronide and then bilirubin diglucuronide. So this bilirubin diglucuronide is transported via the basalolateral membrane via the other transporter, which is your MRP2, into what? Into the canaliculi, of the bile duct, Basically, Unconjugated bilirubin is produced from heme. This unconjugated bilirubin combines with albumin and it is transported across the sinusoidal membrane and it is going to be taken into the hepatocytes. The unconjugated bilirubin basically gets transported via the OATP and the bilirubin transporter. These are two transporters which are basically present near the sinusoidal membrane, which help in the transportation of unconjugated bilirubin into the hepatocytes. The unconjugated bilirubin is not soluble in bile. That is the reason why if the bilirubin has to be excreted, it has to be conjugated. So conjugated bilirubin is the one which is soluble in bile. This conjugation process basically takes place within the hepatocytes. And this is brought about by the help of the enzyme UGT1A1 or the uridine glucuronosyl transferase. So it results in the formation of bilirubin monoglucuronide, then bilirubin diglucuronide, which is then transported into the canalicular membrane into the bile duct via this MRP2. So till here clear. So conjugation happens in the liver and conjugated bilirubin is excreted into the bile. Now once that is done, you have bilirubin diglucuronide. Via the bile it enters where? Via the bile duct. We know that the bile duct comes here and it enters where? It enters the intestine. In the colon, it is deconjugated by the colonic bacteria and it results in the formation of urobilinogen. Urobilinogen, 20% of which undergoes enterohepatic circulation, where whatever is the deconjugation by the colonic bacteria, 20% goes back into the liver or enterohepatic circulation. 80% gets excreted in the stools. And there are traces which are found in the urine as well. So this is how the entire bilirubin is metabolized. It is excreted in the form of urobilinogen. Okay. So bilirubin is basically produced as a result of heme synthesis. So the bilirubin that is produced as a breakdown of heme is unconjugated and it is not soluble in bile. So it has to undergo conjugation process within the liver. So it is transported via the OATP and it undergoes conjugation via the UGT1A1 enzyme. So once this conjugation is done, what is the product that we get? It is bilirubin diglucuronide. This is transported by the MRP2 into the canalicular membrane and it gets excreted in the bile via the bile duct, right? Then 20% of which undergoes enterohepatic circulation. So this conjugated bilirubin gets deconjugated by the colonic bacteria, 20% of which undergoes enterohepatic circulation. 80% of which is excreted in the form of urobilinogen in the stools and there are traces found in the urine as well. So this is about your bilirubin metabolism and transport. Okay, fine. Now let us see certain conditions where there is increased urobilinogen in the urine. So let us see certain conditions where there is increased urobilinogen in the urine. So when will there be increased urobilinogen? In conditions where there is jaundice or there is increased bilirubin production such as hemolysis. So whenever there is hemolysis, there is increased heme, increased bilirubin production, increased urobilinogen in the urine. When will there be absent urobilinogen in the urine? When will the urobilinogen be absent? We know that for the urobilinogen to occur in the urine, the bile should correctly flow into the intestine, right? So that means that the conjugated bilirubin should appear in the bile. For that to happen, the bile and the biliary tract should be intact. So whenever there is an obstructive jaundice, which basically means that there is a problem with the biliary tract. So whenever there is an obstructive jaundice, which basically means that there is a problem with the biliary tract, then the bile cannot flow. It cannot flow into the intestines. If the bile does not flow into the intestine, there is no question of urobilinogen occurring in the stool or in the urine. So absent urobilinogen in the urine basically means that there is an obstructive jaundice. Increased urobilinogen means that there is hemolysis. Right? So there is increased heme, increased bilirubin, increased urobilinogen or in hemolytic jaundice. Okay? So this is how urobilinogen is used to differentiate between obstructive jaundice and your hemolytic. Hemolytic is also called as your prehepatic jaundice. Fine? Okay. Now let us understand some normal values. So what are the normal values of bilirubin in our body? So total bilirubin has a range of around 1 to 1.3 milligram per deciliter. Total bilirubin is 1 to 1.3 milligram per deciliter. Indirect bilirubin is 0.2 to 0.9 and direct bilirubin is 0 to 0.3, right? So about 15% is direct and the rest is indirect. Okay, total bilirubin is only around 1 to 1.3 milligram per deciliter. Fine. Now let us understand this concept of hyperbilirubinemia, right? So let us understand the concept of hyperbilirubinemia. So hyperbilirubinemia can be classified into two types, which is your direct hyperbilirubinemia and your indirect hyperbilirubinemia. So direct bilirubin is nothing but your conjugated bilirubin, the bilirubin which you obtain in your bile, or bilirubin which you measure as your direct fraction, which is your conjugated bilirubin. And indirect hyperbilirubinemia basically refers to when the unconjugated bilirubin fraction gets elevated. Okay. So let us understand that direct bilirubin, when will it increase? Whenever the process is in the liver or after the liver in the bile duct, right? So hepatic or pre-hepatic jaundice can result in direct hyperbilirubinemia. So understand this very basic concept. Conjugation basically takes place in the liver. Followed by conjugation, the conjugated bilirubin has to be excreted in the bile. So any disease process that affects the liver or the bile duct, any disease process that affects the liver results in a hepatic jaundice. Any disease which affects the bile duct results in a post-hepatic jaundice. So either of these two disorders can result in an increase in the bilirubin. Agreed? Which fraction will be affected? It is the conjugated fraction that will be affected. And the conjugated fraction is also called as your direct hyperbilirubinemia. Okay? And when this fraction is more than 50%, that is when we call it as your direct hyperbilirubinemia. What happens in indirect? In indirect hyperbilirubinemia, your unconjugated bilirubin fraction is higher. When does the unconjugated bilirubin become higher? That means when there is heme synthesis is more. And this is what we call as your pre-hepatic jaundice. Pre-hepatic jaundice. So what happens here? The disease process is happening before the entry of bilirubin into the liver. So what type of bilirubin is there that time? It is your unconjugated bilirubin. And why is that happening? It occurs with conditions where the amount of heme is more. For example, in hemolytic anemias. In hemolytic anemias, what happens? There is breakdown of RBCs. When there is breakdown of RBCs, there is more heme available as a substrate for bilirubin formation. And which type of bilirubin increases? It is your unconjugated bilirubin. And what is the site at which there is a pathology? It occurs before the entry into the liver, and hence it is called as pre-hepatic jaundice. Okay. So this is about your basic classification. So direct hyperbilirubinemia basically refers to an increase in the conjugated bilirubin. And what disorders can affect this? It can occur due to diseases affecting the liver or diseases affecting the biliary tract, because once you are having conjugated bilirubin elevated, that means that the conjugation process has happened, but there is some problem with the liver or a excretion of the conjugated bilirubin. So hepatic and post-hepatic jaundice results in conjugated bilirubinemia, and whenever there is an indirect or an unconjugated hyperbilirubinemia, the pathology is a pre-hepatic process such as hemolytic anemia. So till here clear? So when the unconjugated bilirubin fraction is more than 85%, that is when you call it a indirect hyperbilirubinemia. Fine. So what are the causes? What are the causes for direct hyperbilirubinemia? So direct can be due to hepatic post-hepatic jaundice, that is due to multiple causes that we know, like viral hepatitis or any disorder of the biliary tract. The genetic causes that you should be remembering are your Dubin-Johnson syndrome and Rotor syndrome. Genetic causes for direct hyperbilirubinemia is your Dubin-Johnson and Rotor. Then indirect hyperbilirubinemia, the inherited disorders are Gilbert syndrome and your Crigler-Najjar syndrome. Okay. So whenever there is hemolysis, the indirect bilirubin is high. So you do have a jaundice, that is fine. What are the other tests that you can see? You will see that there is a HB drop, the hemoglobin keeps on dropping because of hemolysis. Apart from that, you can have an increased LDH and you can have a decreased haptoglobin. Okay, so these are the other evidences for indirect hyperbilirubinemia. Okay, so till here clear? I hope we have understood till here. We have seen the transport of bilirubin, the metabolism, and we have seen what are the basic two types of hyperbilirubinemia. What is direct, what is indirect, what is conjugated, what is unconjugated, and the causes for the same. Now, let us understand the next part when you do your liver function test. One is your bilirubin, second is your liver enzymes. So, when the next part is your understanding of your liver enzymes. So, when you look at the liver enzymes, these are the enzymes that you should be aware of. So, first is your aspartate transaminase or your SGOT, and second enzyme is your alanine transaminase or your SGPT. The third enzyme is your alkaline phosphatase. ALP is alkaline phosphatase. Okay. So, AST, which is also your SGOT, aspartate transaminase, is produced in the liver. But apart from that, AST is also produced by skeletal muscle. So, it can be elevated in conditions where there is breakdown of your skeletal muscle like rhabdomyolysis. Then, AST can also be elevated in conditions where the cardiac muscle involvement is there, similar to myocardial infarction where there is damage to your cardiac muscle. So, AST is an enzyme which is produced from the liver, but AST can also be elevated in rhabdomyolysis and in MI. Okay. So, the other enzyme which is your alanine, ALT is alanine transferase or SGPT is more liver specific, So, whenever you have liver damage, the first thing that you will see is your bilirubin in your liver function test. Then you see whether this is your direct or your indirect and you know the causes. The second will be your liver enzymes, which is your AST and ALT. Apart from that, there are certain other enzymes as well, which includes your ALP and your GGT, which we will be looking at. So, AST and ALT are also, when they are elevated, they are indicative of liver damage. Okay, so ALT is more specific for the liver than in the AST. And ALT requires a specific vitamin which is required for its function, which is your pyridoxal phosphate. Okay. So, ALT requires PLP or your pyridoxal phosphate. So, ALP basically requires your PLP or your pyridoxal phosphate for its function. Okay. Now, when you interpret your liver function test, what are the patterns of AST-ALT elevation is what we will be looking at. So, the first thing that you can easily remember is what are the situations where AST-ALT is elevated in thousands, right? So, there are only very few situations. One is very important, ischemic hepatitis. Where do you get ischemic hepatitis? In severe right ventricular failure. Okay, you can have congestion of the liver and you can have ischemia. So, ischemic hepatitis or congestive hepatitis is a cause for AST-ALT elevations in thousands. Okay, fine. Then the second one is your toxins, right? Second one is your toxins. Okay, and the third one is your viral hepatitis. Though viral hepatitis is very rare, but it can result in AST-ALT elevations in more than thousands, right? Apart from that, some forms of drug-induced liver injury can also result in this. So, what are we looking at? We are looking at liver enzymes and we are looking at the patterns of AST-ALT elevations. So, when the AST-ALT elevations are more than thousands, these are the conditions. And AST-ALT elevations is suggestive more in favor of hepatic jaundice. Basically a process which affects the liver. Okay, what are the normal AST-ALT values? Normally, it is less than 30 international units per liter. So, usually the AST-ALT levels are less than 30. Okay. Now, we have seen the conditions where AST and ALT are more than 1000. Next, what we should be seeing is your AST to ALT ratio. So AST to ALT ratio more than 3 is very much suggestive of what? It is very much suggestive of alcoholic hepatitis. It is very much suggestive of alcoholic hepatitis. Okay. Then AST or ALT increase up to 5 times. Increase up to 5 times, it basically indicates hepatocellular damage, which can be due to any cause, which includes viral hepatitis, for example. Okay. In alcoholic hepatitis, why is the AST-ALT ratio more than 3? This is because in alcoholic hepatitis, the ALT reduces much more in comparison to the AST. The alanine transferase enzyme reduces to a greater extent in alcoholic hepatitis when compared to AST. This is because in chronic alcohol consumption, they can have loss of pyridoxine, they can have pyridoxine deficiency, loss of PLP activity, and hence ALT reduces much more when compared to AST. Okay. So this is about your AST and ALT. So AST and ALT are basically enzymes which are produced from the liver and they get elevated during liver damage, and they are more suggestive of hepatocellular injury. Normal levels are less than 30. AST can be elevated in other conditions including skeletal muscle damage or cardiac muscle damage such as rhabdomyolysis or MI. ALT is more liver specific and it is dependent on PLP, which is a pyridoxal phosphate enzyme. So we have seen the conditions where you have AST ALT more than 1000. Then what is the importance of your AST by ALT ratio? And we have seen conditions where the AST or ALT are elevated up to 5 times the normal levels. Then let us look at the next liver enzyme, which is your alkaline phosphatase. So in your alkaline phosphatase is basically an enzyme which is suggestive of hepatic obstruction or your obstructive jaundice or your post-hepatic jaundice whenever there is damage to your biliary tract, right? So the normal ALP levels are 40 to 140 international units per liter. So there are certain other conditions also where the ALP can get elevated. So ALP is produced from the liver, but apart from that, it is produced from the placenta. So it can be elevated in pregnancy. Then you have the bone ALP, and you have the intestine as well as the kidney isoforms. So any renal failure, pregnancy, any bone disorder, you can have isolated elevation in the ALP as well. So ALP elevation in isolation need not always mean liver disease, or it need not always mean obstructive jaundice. You have to look at the entire liver function test to understand with clarity. Okay. So what are the conditions where you get increased ALP? Any obstructive jaundice, any damage to the biliary tract. For example, biliary stones, gallbladder stones or cholangitis, you can get elevated ALP. Now, when will you think that, okay, this ALP elevation is also because of liver injury? So that happens when ALP is elevated along with GGT and 5' nucleotidase, ALP with GGT elevation, right? So this ALP with GGT elevation is more suggestive of a liver related damage. What is GGT? GGT is gamma-glutamyl transferase, which is also another LFT enzyme. Okay. Many a times GGT can be much elevated along with AST-ALT elevation. This is also suggestive of alcoholic hepatitis, right? So GGT elevation alone is also suggestive of alcoholic hepatitis. So till now, what are all the liver enzymes that we have learned? So we are basically looking at your liver function test. We have seen that the components are total bilirubin, which includes direct bilirubin and indirect bilirubin. Then we have to look at the liver enzymes, which includes AST, ALT, ALP, GGT. Okay. So this is on whole about your basic liver function test. Apart from this, we also have to look at the synthetic functions of the liver. So what are the synthetic functions of the liver? The liver is basically involved in making proteins and clotting factor synthesis. So any damage to the liver can cause a damage to your protein synthesis and clotting factor synthesis. So what happens to the serum albumin? The serum albumin is decreased in liver disease because albumin is produced from the liver, right? Apart from that, how do you look at your coagulation status? We look at the PT, INR and APTT. Usually in liver disease, all of this is elevated and the platelet counts can be reduced. PT-INR APTT can be prolonged because of your damage to your clotting factor synthesis, and you can have thrombocytopenia in CLD. Can have thrombocytopenia in CLD or chronic liver disease. So this is about the various components of your liver function testing. Fine? Okay. Now let us understand the various patterns of liver injury. We have just discussed it in brief just few minutes back. So liver injury, whenever it happens, it results in the elevation of bilirubin that we have already looked at. So whenever there is an elevation of serum bilirubin, it results in a yellowish discoloration to the body. There can be yellowish discoloration of the sclera, there can be yellowish discoloration of the mucous membranes, yellowish discoloration of your palms, soles, abdomen, and this is what we basically call as jaundice. Okay, so jaundice is basically due to elevation of bilirubin, and this can be classified into pre-hepatic, hepatic and your post-hepatic jaundice. Okay, so pre-hepatic jaundice, we know what is the type of bilirubin that will be elevated. There will be increase in your indirect or your unconjugated bilirubin. So why does this happen? This occurs in hemolytic anemia. This occurs in hemolytic anemia. Okay, so there will be an increase in the unconjugated bilirubin in pre-hepatic jaundice, right? And you can have mild AST ALT elevation. It may or may not be there. Okay, you can or cannot have. Most often it is only your bilirubin elevation, right? So ALP GGT is normal. In your hepatic jaundice, the total bilirubin is increased. Total bilirubin is increased here as well. What type of bilirubin gets elevated? It is your conjugated or direct hyperbilirubinemia. Okay, AST ALT will be elevated, and you can see the patterns of AST ALT elevation to have an idea about the suspected cause, right? ALP GGT will be normal in your hepatic jaundice. Then your post-hepatic jaundice is also called as your cholestatic pattern. In this cholestatic pattern, again TB will be high, DB will be high. Your AST ALT will be normal, it can be elevated, it is a plus or minus condition, but your ALP GGT will be high, will be elevated. So ALP GGT elevation is more in favor of your obstructive jaundice or your cholestatic pattern or your post-hepatic jaundice. Okay, so this is about your various patterns of liver injury. Now let us look at the overall view at how these liver tests are done and how do you interpret your liver function tests. So first, in your liver function test, you have to look at your bilirubin, right? So after that, you have to look at your liver enzymes. Now if there is isolated elevation of your bilirubin, then you see if this is a direct or an indirect hyperbilirubinemia. If the bilirubin is elevated isolated, then you see if this is a direct or your indirect hyperbilirubinemia. If it is your direct, right? If it is your direct, bilirubin is elevated, but AST, ALT, GGT, everything is normal, then you can think of your genetic conditions. What are the genetic conditions of direct hyperbilirubinemia which we have learnt? It is your Dubin-Johnson's rotors. Okay. If it is indirect hyperbilirubinemia, you rule out hemolysis, right? You rule out for your hemolytic anemia. If that is not there, then think of your genetic conditions like Gilbert's syndrome. Think of your genetic inherited conditions like Gilbert's syndrome. Okay. Then, you have found that bilirubin is elevated, AST, ALT is elevated. Then what you have to do? You have to find out what is the cause for your hepatic jaundice. What is the cause for your hepatic jaundice? So you have to see the drugs which cause. It can be a drug-induced liver injury. It can be due to hepatitis B, hepatitis C, right? You will have to look for your iron TIBC ferritin because hemochromatosis can result in hepatitis. Okay, iron TIBC ferritin, basically why we are looking for? We are looking for the condition called hemochromatosis where there is iron accumulation in the liver. Apart from that, you can do ANA for autoimmune hepatitis, ceruloplasmin levels for Wilson's disease. Right, so this is about your evaluation for the causes of hepatic jaundice. Apart from that, you can also do an ultrasound to see the structural architecture of the liver. Okay. If everything is negative, finally, if you have to find out the cause for your hepatic jaundice, you have to do a liver biopsy. Fine. Then the third pattern, if you find, is your cholestatic pattern. In your cholestatic pattern, you will have ALP GGT elevation. Alkaline phosphatase and gamma-glutamyl transferase will be elevated. So again, you rule out drugs. There are a lot of drugs which can cause cholestatic liver injury. You look at the drug list and do an ultrasound. What is the function of the ultrasound? Ultrasound in cholestatic liver injury can be used to see the bile ducts. Right? So in this, what do we see? So if the bile duct is dilated, if there is a bile duct dilatation, what does that mean? For example, if there is a stone in the bile duct, your bile duct stone, right? Choledocholithiasis. If there is a choledocholithiasis, or there is a stricture due to a malignancy of sorts, if there is a stricture in the bile duct, what happens to the upstream portion of the bile duct? The bile duct will get dilated. So the bile cannot flow. There is more accumulation of bile in the liver, and what will happen finally? It will result in jaundice. And what type of jaundice is this? This is your post-hepatic or your obstructive jaundice, which results in a cholestatic pattern of liver injury where there is elevated ALP and GGT. So the whole point is, whenever you get a cholestatic pattern, you've ruled out causes. You've seen if there is a drugs or anything that is causing your cholestatic pattern, go ahead, do an ultrasound. If there are dilated ducts, then you have to do a CT, MRCP or an ERCP. CT is your computed tomography. MRCP and ERCP is basically, ERCP is your endoscopic retrograde cholangiopancreatography. Basically, you give a dye and you see through the bile duct and see if there is a stone, stricture, etc., which can be treated appropriately. Now, if there are no dilated ducts, right? So, if there are no dilated ducts, that means what? Then you have to look for autoimmune causes. You look for autoimmune causes. Okay. So, the autoimmune causes which can affect the bile duct, including primary sclerosing cholangitis or primary biliary cirrhosis. Okay, fine. And what do you do for this primary biliary cirrhosis? You basically look for your anti-mitochondrial antibodies to look for this primary biliary cirrhosis. Okay, fine. So, this is what we do. If the bile ducts are not dilated, you look for your anti-mitochondrial antibody levels to see if there is an autoimmune cause for your cholestatic pattern. Okay, fine. Now, if there is isolated elevation of ALP, now we had just discussed that ALP is not produced only from the liver. It can be produced from the placenta during pregnancy, it can be produced from the bone, it can be produced from the kidney, right? So, if there is isolated elevation of ALP, right, if the ALP alone is elevated, then you look at your GGT and 5' nucleotidase. GGT 5' nucleotide is also elevated, then it is a liver problem. You go ahead down that line of doing the ultrasound. Ultrasound is also negative, do an AMA. If alkaline phosphatase alone is elevated, then you definitely have to do a bone evaluation. Okay, you do a bone evaluation to see if it is because of a bone problem. So, ALP elevation can be seen in vitamin D deficiency, it can be seen in hyperparathyroidism, it can be seen in Paget's disease, and so on and so forth. Okay, so this is your integrated approach to LFT. So, let us just revise this once again. So, when you do your liver function test, what all will you be looking at? You will be seeing your bilirubin. If there is isolated elevation of bilirubin, you see if this is direct or indirect. If it is direct, you look for genetic causes like Dubin-Johnson rotor. If it is indirect, if there is indirect, then you see for your evaluation for hemolysis, it's not hemolysis, look for genetic conditions like Gilbert. Then if it's a hepatic pattern, right, if it's a hepatic pattern, that means TB, total bilirubin and direct bilirubin is elevated along with AST-ALT elevation, then you look for this entire group which I have told you here. Okay. If it's a cholestatic pattern, then you do an ultrasound, you see if there is any obstruction. If there is no obstruction, then you have to look for autoimmune causes like primary biliary cirrhosis. If there is isolated elevation in ALP, then you definitely have to do a bone evaluation. Okay. So this is about your liver function test. Now let us understand some of the hyperbilirubinemias in detail. Okay. So the first is your direct hyperbilirubinemias. Your direct hyperbilirubinemias where there is a genetic defect in your, basically in your transporters. Okay. So two syndromes which you should know, DJS is your Dubin-Johnson syndrome and your Rotor's syndrome. So genetic causes of direct hyperbilirubinemia, two syndromes which is your Dubin-Johnson and your Rotor's syndrome. Okay. So what is the gene for Dubin-Johnson syndrome? It is your ABCCA, and which protein is affected? It is your MRP2. We know that MRP2, when we had discussed about the bilirubin metabolism, it is responsible for the transport of conjugated bilirubin into the canalicular membrane for excretion into the bile. So that is affected. So is there cholestasis? No, there is no cholestasis because the conjugated bilirubin is not entering the bile itself. Okay. So serum GGT, serum bile acids, everything will be normal. Okay. So what are the clinical features with which Dubin-Johnson presents? Most of the time they are usually asymptomatic. They have mild conjugated hyperbilirubinemia with otherwise normal liver functions. Okay. So many a times if you have, in ladies especially, if they have an oral contraceptive pill, or sometimes with viral hepatitis, all of these can get triggered. The most important thing, the most important diagnostic test that helps in differentiating Dubin-Johnson from Rotor's is that urine corporoporphyrin levels. Urine corporoporphyrin levels are normal in Dubin-Johnson syndrome. Another characteristic feature that you have to remember is the presence of this black liver on autopsy or biopsy. Presence of this black pigments in the liver. Black liver is what is seen in Dubin-Johnson syndrome. The other genetic inherited condition which is associated with direct hyperbilirubinemia is your Rotor's syndrome. Rotor's syndrome basically occurs due to a defect in OATP. Now OATP we know is responsible for carrying your unconjugated bilirubin into the liver. Okay, so whenever there is deficiency of this OATP, there is no cholestasis, GGT is normal, there is mild conjugated hyperbilirubinemia, normal liver. Two important features which help differentiate Rotor's syndrome from Dubin-Johnson: the liver does not have any pigmentation in Rotor's syndrome, and the urine corporoporphyrin levels can be elevated in Rotor's syndrome. Urine corporoporphyrin levels can be elevated in Rotor's syndrome. Apart from that, when you do an oral cholecystography, you see the visualization of gallbladder. When you do the oral cholecystography, the gallbladder is seen in Rotor's syndrome, but it is absent in Dubin-Johnson syndrome. Okay. So this is your important differences between your Dubin-Johnson and Rotor's syndrome. These are your genetic causes for direct hyperbilirubinemia. Let us look at the next causes. The next causes is your genetic causes for indirect hyperbilirubinemia, where there is unconjugated bilirubin which is higher. So this can be of two syndromes, which is your Crigler-Najjar syndrome and your Gilbert syndrome. So the two syndromes are your Crigler-Najjar syndrome and your Gilbert syndrome. Crigler-Najjar is divided into type 1 and 2, and then we have your Gilbert syndrome. Okay, so all of them you can see here, there are certain very important differences. The most important difference is that the most important thing that you should be knowing is that all of them have a problem with this enzyme, which is your UGT1A1 enzyme, which is your uridine glucuronosyl transferase, which is your conjugating enzyme. So there is a defect in the conjugation. Okay. So what happens in Crigler-Najjar? This enzyme is absent. This enzyme is completely absent in Crigler-Najjar type 1. In Crigler-Najjar type 2, it is markedly reduced, only 10% is functioning. In Gilbert syndrome, up to 10 to 30% of the normal enzyme activity is present. So this very important point you have to remember is how to differentiate these three. All of them have a problem with the conjugation enzyme. The enzyme is completely absent in Crigler-Najjar type 1. It is reduced to 10% in Crigler-Najjar type 2. 30% activity is there in Gilbert syndrome. Okay, and all of them are predominantly an autosomal recessive inheritance. All of them are predominantly an autosomal recessive inheritance. The next point is that there are certain phenotypic differences in all of these. In Crigler-Najjar type 1, the total bilirubin is usually more than 20 and you have an indirect hyperbilirubinemia. Okay, other tests are usually normal. Okay, and the patient has kernicterus. The patient has kernicterus. So, this has the worst prognosis. This has the worst prognosis. It can present with neonatal jaundice, severe jaundice, bilirubin more than 20, indirect hyperbilirubinemia, and they can have kernicterus. Kernicterus basically when the bilirubin can cross the blood-brain barrier and cause CNS damage, and they can have long-term neurological side effects and developmental problems. Okay, fine. And they do not have any response to phenobarbital. So, phenobarbital test is basically a hepatic enzyme inducer. Induces this UGT1A1 enzyme. So, this test is basically used to determine whether there is any response or no. So, phenobarbital test, phenobarbital is basically an hepatic enzyme inducer. So, response to phenobarbital basically means that when you give phenobarbital, there should be some conjugation happening and bilirubin levels should start coming down. But because this is the most severe form, the enzyme itself is absent, there is no response to phenobarbital. But in Crigler-Najjar type 2, it decreases the bilirubin by more than 25%. And in Gilbert syndrome, the bilirubin can in fact come to normal. Okay, fine. So, what about type 2 and Gilbert syndrome? There is no kernicterus. In Crigler-Najjar type 2 and Gilbert syndrome, there is no kernicterus. So, the worst prognosis is your Crigler-Najjar type 1. And your Gilbert syndrome most often is seen in a lot of patients as undiagnosed. When you just do a routine lab investigation, they find these elevations and then they present to you and they remain asymptomatic for a lifetime. They remain asymptomatic. Okay, fine. Now, what about the bile characteristics? What about the bile characteristics? The bile is pale and colorless because it is unconjugated bilirubin which is not soluble in bile. So, bile is pale and colorless in your Crigler-Najjar type 1. Okay, it can be pigmented and it is normal color in Gilbert syndrome. It can be pigmented but the fraction is very less in your Crigler-Najjar type 2 and it is normal color in Gilbert syndrome. Okay, so this is about your direct and your indirect hyperbilirubinemias. So, till now what all have we learned? In this session, we have learnt about your basic structure of the liver, we have understood your approach to liver function test, and we have understood your different types of genetic hyperbilirubinemias. Thank you.